Okay, ladies and gentlemen, thank you so much for making time to join us for today's CME. We have an exciting CME lined up for us, and I guess we'll get right into it. Allow me to present our moderator for the day, Dr. Jeffrey Muraguri, who is a consultant ophthalmologist at the Machakos Level 5 Hospital. Today we have a businessman with us. So he's also a proprietor of an eye clinic at Machakos Doctors Plaza, which is in ABC Imani building. So karibu sana, Dr. Jeff, to moderate our session for the day and to introduce our speaker for the day as well. Thank you.
Thank you, Dr. Wanjiku. Thank you all for making time to attend this presentation. Let's get right down to it. So our speaker today is Dr. Korir. Dr. Korir is known to most of us. He's a consultant ophthalmologist and subspecialist in cornea and anterior segment. And he's also the proprietor of Ocean Eye Center in Nyari. So Dr. Korir is going to take us through the topic for today, which is acute corneal hydrops. And I'm kindly requesting all participants to kindly mute your mics. And please feel free to post any questions in the chat box. I think Dr. Korir, maybe I've not done you justice. Maybe as you start, maybe you can add anything I've left out. Thank you, Dr.
Thank you, Dr. Muraguri. I think that is adequate introduction. I hope I'm audible.
Yes, Dr. We can hear you loud and clear.
All right, so I'm just going to go ahead and share my screen. So, yeah, so as Dr. Muraguri has said, I practice cornea and anterior segment in Mombasa, and I just thought of presenting a simple topic that we all face, and we still don't seem to have a very clear answer on what to do. So this, I'll share two cases that I encountered recently of acute corneal hydrops, and then I will discuss about corneal hydrops in general. I'll share with you how we manage those cases that we had, and then we'll have a Q&A session. So my first case is an 8-year-old boy who presented to us last month. He's known to have allergies and had been on treatment somewhere in a neighboring county. But he presented with a sudden reduced vision, tearing, and cloudy vision on the right, on his left eye. So on examination, the right eye, so he presented with the left eye complaints, which was hand motion with vision, but his right eye also had poor vision of 2400. IOP on that eye was 8. The eyelids were within normal limits. The conjunctiva, he just had tarsal papillae. The cornea was clear, and there was a cone with Manson's positive sign. Anterior chamber was deep and quiet. The rest of the eye findings were generally normal. The other eye was hand motion movement. The intraocular pressure was not done. Normally we do it at the screening area at Lighthouse. So sometimes we've told them, if you see an ulcer, you don't take IOP. So I think the person saw something unusual. They didn't take IOP. Lids were normal, had tarsal papillae. He had circumlimbal congestion. So the picture on your right of your screen is actually the patient at presentation. You can see circumlimbal congestion. There was a central clouding of the cornea, and you could, with a slit lamp, you could see a decimate membranes break in the posterior with a bit of bubbles in the AC, in the stroma. The anterior chamber was deep, and we could see the chamber from the periphery. Iris appeared normal, but other details were not clear, so we couldn't assess the pupil lens and all that. So that was our first patient. Second patient actually presented to us exactly a week ago on Thursday. He's a 10-year-old boy, known also to have vernal keratoconjunctivitis, presenting with a right eye sudden reduction of vision, clouding, and tearing. He had interestingly presented to us again in 2023 with the same complaints on his other eye, the left eye, and we treated it and it resolved. So his findings on the right eye, the right eye had light perception. This was the eye that was affected. IOP was 3. This time we did it. Leads were, he had blepharospasm, tearing, matted lashes, tarsal papillae, also had circumlimbal congestion, and he was tearing profusely. He had a large cone, central corneal bullae, central corneal edema, clouding, Manson's positive. The other details were not visible. The other eye that he had suffered the same symptoms in 2023, his vision was 2100, IOP was 11, the leads were normal, conjunctiva, mild injection with the papillae. He had a central corneal scar and also Manson's positive. Other details were normal. I would like you to take a video for this second patient. And so I'm just going to play the video. Tell me if there's any problem with it playing. I'll try and play it twice. On the about 2023, you can still see Manson's is positive. Some scarring is there. His vision on this side was 2200, a little bit central. I think it's seeing it from up here. The visual axis up there. So that is our second patient. I'll discuss what we did to these patients much later on. So I want us to discuss acute corneal hydrops briefly, so that then we'll discuss how we manage these patients. So acute corneal hydrops is an uncommon complication of corneal ectatic disorders involving corneal edema due to decimate membranes rupture and can cause impaired vision and eye pain. So basically you have an underlying ectasia. You know, keratoconus is the commonest. You can have keratoglobus or pellucid marginal degeneration. So those are the 3 that can cause. Epidemiology, who is affected? Outrightly, we don't have data locally. I know Dr. Zara has done a few things. I didn't get time to look at her study to see how much it is. I'll probably compare it later, but I'll just give you some of the results from from the world out there. They say the incidence of hydrops is 0.2 to 2.8%. It is rare in keratoglobus and pellucid marginal degeneration, as I had said. Here it says that it's common between the age of 20 and 40. I mean, clearly our patients present much earlier with keratoconus and much more severe forms from Dr. Zara's studies. And also the hydrops that we see is much younger. As you've seen, my patients are 8 and 10. And even the one who presented at 10 years, his first presentation was in their 8. Males are more predisposed and have double the risk compared to females. I know I have a small sample, but both of my patients role of family history in the etiology, but it's variable, not conclusive. Some ethnicities in some studies have suggested that some certain ethnic communities tend to have more of these acute hydrops. In New Zealand, they found individuals of Pacific Island ethnicity who had a higher risk of hydrops compared to individuals of European descent. Published a paper in 2015 where they had done a study in the population in the UK, and this is just a quick summary. This is Barsam et al. And they just looked at their data sets in their health system and also inquiring from the clinics, from the doctors, and they grouped them into white, Asian, black, mixed, or other. So, you know, they had a lot of white people, obviously, but less black people. But compared to the UK census of 2011, they looked at the incidence, and you can see that the black population seems to have a higher incidence of 0.37. So this generally, you know, is a little bit in keeping with the kind of severity of allergy that we tend to see. So I would tend to believe this more to be more of a true picture of our population. So we do need to do a lot of studies, and I think this is a good opportunity for some of the residents to even look at the data sets that we have. I did call a few people just to tell me what they are, including Zara, tell them what they see about this acute hydrops, but most of them just have data, but they haven't analyzed. So it would be good for somebody to have a look at them so that we get to know how ours presents. I think it's very unique. So the risk factors that are associated with acute hydrops is atopic disease. Rubbing the eye actually is the highest because your cornea has this ectatic, is thinned out, and you're putting more intraocular pressure like you're rubbing, and you can rip the descemetes. Interestingly, patients with learning disabilities, patients with Down syndromes, I think this have a higher incidence. I think possibly because of just basically taking instructions might be a little bit of a problem. Some people have studied the anatomical characteristics of the corneas that tend to develop acute hydrops, and they found some anatomical variances that may suggest that the patient is at a higher risk, such as epithelial thickening, if you have stromal thinning, hyperreflective anomalies, and absence of cornea scarring predisposes you to getting the acute hydrops. Steep keratometry, prior acute corneal hydrops in one eye you're at a higher risk of getting in the other eye, and this we have seen clearly in our patient, the second patient. And then elevated intraocular pressure. So these are the risk factors, and you can say that if we are able to modify some of these risk factors, we can try and do some primary prevention for this, getting patients to not developing the acute hydrops. So you can really try and control your allergy, reduce exposure to allergens if you can, teach patients also reduce the risk of developing acute hydrops. So I did find that a video from Damien Gartinel. He's I think he's French, a cornea surgeon, very good, and he does a lot of study with keratoconus. And he did an MRI.
Here's an MRI of what it looks like when you rub your eyes.
Basically, it's an MRI video. It's good to show to patients how much trauma they do to the eye whenever they're rubbing it, so that they see it, and it just shows you how much.
Here's an MRI of what it looks like.
How much pressure you put on the eye and how much it can cause these problems. So I'll just revisit the pathophysiology. Basically, you have an acute break of the descemetes membrane. If you look at the picture at the bottom right of your picture, it's just a histology picture of a ruptured and rolled up descemetes membrane, and you have an egress of fluid into the stroma, causing edema. The rest of the slides just show some of the changes that happens in the eye whenever you have keratoconus. This first one, written A, just shows how much usually you get the apical thinning, and you can actually get Bowman's membrane rupture and ion deposits on these levels. That's how you get Fleischer's ring and all that. So all these are some of the things that happens with keratoconus. But the main pathophysiology of rupture of the descemate membrane, and you have egress of fluid into the stroma, causing edema. So I'd mentioned about primary prevention, control the progression of the ectatic diseases, whether it's keratoconus, keratoglobus, or pellucid, minimize eye rubbing, control atopic diseases, and exposure to allergens. How do we diagnose keratoconus? She's usually very standard, usually sudden onset, reduction of vision, pain, and photosensitivity. It may be spontaneous on its own, or it may be precipitated by eye rubbing, sneezing, nose blowing, or any other IOP increasing activity. So any vasalval maneuver activity or that. So that can suddenly rip the descemetes, especially if it's already under tension from the ectatic diseases. Ask about hydrops history on the other eye whenever you're getting history. And sometimes the patient is the first time you're diagnosing them to have keratoconus. So always ask whether they've had keratoconus or been treated for any of these things. So, this is some of the things you want to look out for the history. When you take the vision, obviously the vision will be reduced because of the edema and usually centrally involving. And then the IOP will be falsely reduced. I think you saw the second patient who we took IOP this time, it was reading 3. And it's just because of the, the fact that the cornea is spongy and, it's all soaked up and moist. So it's not, you're going to get a lower reading. So it's a falsely low reading. So you just need to be aware of that. And then on slit lamp exam, you'll get this central edema, assess the degree and the extent. Usually the prognosis is associated with the size of the edema that the cornea has. And interestingly, if you stain, side ladles might be positive. And it's not that the cornea has ruptured, but actually usually stromal exudation of fluid from the stroma. So that's what happens. And then always examine the other contralateral eye for signs of ectasia, signs of any scarring, to show any former acute hydrops. Do you do any imaging? Yes, imaging can be useful. Although most of the diagnosis is clinical, you can do imaging for documenting and also for following improvement. You're able to monitor progress of the patients. One of the tests you can do is an anterior segment OCT, which you can see at the top here. And in this OCT, it shows there are 3, A, B, and C. The first one just shows you a ripped decimates over here and rolled margins. And you have all this edema, and you've got fluid clefts in between here. You've got clefts of aqueous that goes behind there. So you can get that, you can measure the thickness and be able to follow up the management. So the second patient, you can have a break of the decimates, but actually without a rolled margin. So this one is called a linear break. In this second patient, it just shows that there's a decimates detachment, but there's no break. And you can just see how taut this is, just like a bow waiting to rupture. And I think this is what may be preceding before you get the acute hydrops. So an OCT can be useful, and maybe a good idea to be doing them whenever you have these ectatic patients you're following. Just do an OCT in keratoconus patients that come, and just to monitor to know how they're doing and whether the decimate membrane is attached or not. Obviously, in teaching institutions, you have in vivo confocal microscopy where you can study the fibers. You'll see the fluid clefts. Sometimes you can see inflammatory cells in there. Ultrasound biomicroscopy, basically it's an ultrasound with a higher frequency, gives very good pictures, and I think I've shared one at the bottom there. It gives you all the way from the angle, sometimes the lens down here, and it can give you a bigger picture of how the acute hydrops is. So I think in this patient, this was the acute presentation, and later on after it has resolved, and you can see how, and the scarring there. So these are useful equipments to have to be able to do imaging. Obviously, I'm just mentioning corneal tomography for completeness sake, because you want to look at the other eye that's not affected, because it'll be difficult to do it on the eye that has acute hydrops, but it's good to do it on the other eye to just be, to know whether there's any ectasia or not. There are differentials to acute hydrops and anything basically that causes corneal edema. So the first differential is that you have to keep in mind is all those ectatic diseases. A patient presents with acute hydrops the first time, you don't even know they have keratoconus, keratoglobus, pellucid. Definitely those have to be in your differential diagnosis. Infectious keratitis, especially the ones that give you endotheliitis, like viral keratitis, can give that edema and can give you a picture of acute a picture of central corneal edema that might look like can look like the acute corneal hydrops. Uveitis, again with endotheliitis, can give you this problem. Fuchs endothelial dystrophy, I think we discussed some time back, can give you edema in like stage 3 to stage 4. And then post-surgical edema, we have basically post-surgery, patients can develop edema. And acute graft rejection. So most of this, with the history, you'll be able to differentiate. But I'm just mentioning it there for completeness sake and for students for exams. So how do we manage this? again, interestingly, most of them are anecdotal. Most topical drops are anecdotal. Nothing really published that says that works for these diseases. So most people manage symptomatically, and because the condition resolves on its own from between 2 and 4 months. 2 and 4 months is a long time if you think about it, but I'll leave that there at this point. But anti-glaucoma medication, especially if you're going to have egression of, if you're having sidal positive, or sometimes you're thinking you want to reduce the aqueous that is percolating into the stroma. Some people have tried that. Hypertonic saline to kind of detach to dry the cornea. Cycloplegics for pain control. Steroids to reduce for comfort and reduce inflammation. You saw our patients all were inflamed, uncomfortable, tearing, circumlimbal congestion there. Antibiotics, you're having already an ocular surface that is disturbed, inflamed. So sometimes some people give antibiotics. And then I've said if sidals is positive, you can try aqueous suppressants and we'll put a patch. Basically, you're trying to reduce any fluids coming out. So all this medical management, this is what you do, symptomatic management. Some people even put contact lenses if it can hold, because some of these corneas are very steep. So all these are anecdotal. Surgical management, you can put air or gas, and I think Dr. Mushai presented it in our first OSK meeting in Nairobi Hospital. Some of the cases he had done, he had put C3F8 gas, and the cornea seemed to clear a lot faster. So the thing with the gas is that it works, but it doesn't change the final vision. So if you're going to leave it for 2 months and you put some in gas and some watch, the vision is going to be roughly the same. But at least this other one, if you put gas, it resolves quickly. The second one is compression sutures. In this technique, you basically stitch the cornea. You compact the stroma. And this kind of help the detached decimates to reattach, and you sort of like squeezing and drying the cornea. If you think of it as a sponge, you're kind of helping it out. So it reduces intrastromal clefts that have got fluid trapped there. And after that, you can usually combine it with gas, or you can just put an air bubble. And you can do the stitching, interestingly, partial or full thickness. So some people, some interesting papers have come out that it doesn't matter whether they do partial or full thickness. The whole idea is to try and approximate the decimates. So that's compression sutures. The other technique is endothelial. You can straight away do a DMEC, decimate membrane endothelial keratoplasty, or decimate stripping, automated endothelial keratoplasty. Interestingly, this one, you can do it in the acute period, and this has been shown to hasten the clearing of the cornea and also improves the vision, a little bit better vision, and it lessens the need for PK. Most of these patients don't end up having a PK. I guess it's because you're addressing the pathology. You had a broken decimate, you put a new one, and it seals that area, and also now you have an active, healthy endothelial pump that is clearing the cornea. So this seems to be like a good, promising one, but it's difficult to always have this tissue ready whenever these people present. And finally, the other solution would be surgical PKP or DALC. Obviously, this is better done once everything has resolved. You've got a scar that is sitting on the visual axis, then you do a PKP or DALC, depending on the depth of the scar. So, we looked at all these solutions that we have, medical for our patients. We looked at these ones that have gas. We don't have gas, difficult to have assessment. We have sutures and everything. And this sounds like a cornea repair. DMEC, difficult to get tissue, expensive to the patient. PKP, not yet time. So we decided to try compression sutures in these patients. So we scheduled them for, anyway, before I finish, complications. You can have a debilitating scar in the cornea, which you've seen at the central. You can get infections that you have already a surface that's affected. You can have pseudocysts formation, basically those little big bullets that are forming. They can form, they can rupture, and already compromised epithelium is a highway for infection. And then obviously you can get corneal perforation, especially in very thin instances. Prognosis, it resolves, usually resolves in 2 to 4 months, which is a really long time. And the cornea scar, if the cornea scar forms outside the visual axis, it may flatten the cornea and actually improve the vision. So in some patients, after all this journey, the vision actually improves because of the flattening from the scar. And sometimes it becomes easy to fit contact lenses because the cornea is a bit flatter. So that's a good thing that can happen. But if a scar is on the visual axis, it will impair vision. Prognosis, if it is large and if it stays for a longer period, it results in corneal vascularization. So basically, if you have a big corneal edema involving a lot of your cornea, and if that stays longer, then you'll develop neovascularization. The prognosis for that is worse. So you would like to treat quickly. So I'll go back to management of our patient, GJ. If you remember, this was the one that presented with the left eye that had edema. First time coming, and we diagnosed he had keratoconus on the right side, and then the other eye. So for him, he wasn't tearing and uncomfortable a lot. We just started him on hypertonic saline. We started him on opatadine, both eyes, but hypertonic saline on the eye that had an infection. And then we did a compression sutures. So I'll share with you a video on how we do the compression sutures. Basically, basically you do it in theater, and you do it like you're doing a cornea repair. But you want to take big, wide, and long bites. There's no need to do like full thickness. I mean, the cornea is so thick, sometimes it's just difficult even for the needle to go through. And the whole idea is to kind of compress. The whole idea is to compress that spongy cornea. So you can do whatever technique you use to repair the cornea, and just make sure it's nice and tight, because as it starts to dry, these sutures become loose and you want to later remove them one by one. So this is basically the technique. I start from the end. So I did this side, and then right to the opposite side, over here was the next one. And then we closed all the way. So the decimate break was this way. So you want to go perpendicular as much as possible for these cases. And if you notice, the needle is very small, so you kind of have to push it, make sure you drive most of it out and then get it out. It gets trickier when you reach the middle, because it's like the needle is disappearing. I'm sure you can try and avoid touching the tip of the needle as it comes out. At the same time, try and push the end of the needle so that you get most of the suture in there as you're doing it. So it's basically like a cornea repair. So this was the patient at presentation. That's the first image here. And this was immediately after we had done. So this is the suture. You saw the video going. And then the rest, we put all this. And obviously, as you tighten, you might have to redo some of them, because the whole cornea changes. And you might want to put, redo others. Interesting, it's very spongy, and it feels like you're about to perforate it, but it doesn't. So basically put those, and then put a little paracentery, small, and then push in an air bubble. The whole idea is to try and approximate the decimates. So you have an air bubble there, almost 90%. So you leave that, and you put a contact lens. For this first patient, I didn't put, but I had to remove a suture very soon, and it wasn't pleasant immediately after surgery. So always put a contact lens so that it buys you time. And it's more comfortable for the patient. So this was a patient day 1 post-op, And you can see already it's starting to clear. The periphery is a lot clearer. You still have your air bubble about 20%. And then this is the patient 1 week after, and it's starting to scar, and you can see how faster it's healing. And then this is a patient, interestingly, came today. I took this video today, this photo today. So you can see the history of 2 months with just these compression sutures. We've already speeded up the process of this child recovering. Within a month, already the cornea is clearing. So he had some loose sutures, which I removed, but the plan is to remove the sutures now that it's getting clearer. So that is GJ, the first patient. This is the second patient who just presented last week. This was at presentation. This is after the suturing with an air bubble intra-op. This was first day post-op. And you can clearly see this presentation and this, in a very short time, you've crossed the patient to this level with just compression sutures, which are very easy to put. So in summary, acute corneal hydrops present as a sudden decreased vision in patients with corneal ectasia due to a break in the Descemet's membrane. It can resolve spontaneously over 2 to 4 months. Faster resolution with surgical intervention. Compression sutures are effective and technically easy. Patients may still need a PK if the scar is visually debilitating in the end. Thank you. So I think my whole idea was just to share you my little experience with some of the things I came across with in terms of managing this acute corneal hydrops that can be really fast and help the patients be more comfortable and get back to their life much faster. Thank you.
Thank you, Dr. Korir, for the presentation, and I think also for the videos. It helped us to at least visualize what was being discussed. Maybe we can go to the question segment. So the first question is from Dr. Shiko, and she's asking, how can one determine the Descemet break on the slit lamp exam? And also she has another question is, can we consider an optical iridectomy for the second patient that you presented? Thanks.
Okay, I can answer those ones real quick. Descemet's detachment is very easy to see on the slit lamp, especially if you just put a slit and focus to try and look whether there's a membrane lagging behind. Usually you can with this acute hydrops, you can actually see even a clear area in the middle, like a line. So I think that would be the easiest. But if you want to see, like after cataract surgery, whether you've ripped your Descemet or not, sometimes you can put glycerol on the cornea, and that clears the cornea a little bit. And you, with your slit lamp, you can just do a nice little slit and go side to side. Normally, the Descemet rolls like a scroll, and you'll be able to pick it. And the edema sometimes can guide you where it could be. So that's how you can determine Descemet's membrane break. An optical PI, well, good suggestion, but I don't think it's worth in doing. I find that very invasive, given that most of this clears on its own. I guess you just leave it and then, it heals on its own. No need to invade into the iris and all that. I think you just leave it and see how it recovers and then deal with the cornea. I think it's a cornea pathology. I would leave it there. Thank you.
Okay, thanks. So the second question is actually from me. There's a risk factor that was mentioned. I saw it in the literature and I've also seen you mention it. So according to the literature, the absence of corneal scarring is a risk factor for acute corneal hydrops. Maybe just help me and anybody else understand that better.
I think I think I'll say it the other way around. If you have a scar, it's better. You will not get, it's unlikely you'll have an acute hydrops. Think about it. You have already like cross-linked in a way because your lamellae or the fibers in the cornea are like compact already. That's one. So it's difficult for it to rupture. So if you that's why it's difficult. Once you've gotten an acute hydrops, it's difficult to get a second one because the first one causes scarring. So it's not going to get a hydrops. Scarring occurs when you've got, those spaces, those small little spaces in between the cornea. And that's the whole idea about cross-linking. You're compacting those with covalent bonds. Thank you.
Okay, thank you. Dr. Omondi was asking if you could please expound on the gas treatment. How exactly is it done? Thank you.
I think I'll throw that question back to, I've seen Shafiq mention that it clears in 2 to 3 days. And I know Dr. Mushai had presented something on how it's done. But what I do know is that it's like just put a bubble of gas that is expansile, and as I said, it speeds the process. It doesn't, improve. I mean, it doesn't improve the. It's not like DSEC or DMEC. You still get your scar the way you would have gotten it. It's just that it speeds things up. It gives you comfort a lot more. Thank you.
Okay, thank you, Dr. There's a question from Dr. Khan asking about what determinants of the patient's presentation on OCT guides the choice to use intracameral gas versus compression sutures. What determinants, if any, will inform your management option? Thanks.
I don't think there are any characteristics that would make you choose one technique than the other. I think at this point, there are not so many studies, quite frankly. I think that one needs a randomized control trial to kind of figure out. But I guess right now, all I'm saying is just use whatever technique you have. Try to speed up. 2 months is a lot of time. That's an entire school term for a child. You want to sort them quickly. So use whatever you have. Yeah.
All right. Thank you, Dr. Now, Dr. Walter is asking, how successful is PKP or DLK in view of VKC that most of them have?
I think they are good generally. If PKP generally good ones, for I'd say the ectasias generally, they have a better prognosis. But keep in mind that some of these patients with VKC, over the years, they get limbal stem cell deficiency. So that's usually the one thing that you look at before you do transplants, and that's what makes the prognosis poor. I don't know whether there's anything to do with whether if a patient has had acute hydrops, whether that PK is worse than a patient who just has a straightforward keratoconus. But in my view, if it has scarred, there's no vascularization, I think it should be okay.
Okay, thank you, Dr. There are just 4 more questions left. Dr. Khan is asking, in the instance where you have a large decedent membrane break and you use gas, is there a fear that some of the gas might actually force its way into the corneal stroma? Is that something that's been observed clinically?
I think I'd give these gas questions to retina people, but I don't think it percolates into the cornea. I think it just behaves like an air bubble, like all the rest of the gases we put in the eye.
All right, thank you. Dr. Shiko is asking, what is the spacing between the sutures? Can we use 9/0 as the needle is slightly longer?
I would stick to 10-0 for the eye, for the cornea, because it's just that the needle is so big in the 9-0. Going with it already with a very spongy cornea, you might chiswire wire things. So I would suggest you just use the 9-0, the 10-0. You can just compact where you can. You don't have to go like long. Just compress whatever cornea you can. But I would stick to 10-0 because they are small. Sometimes as you bite, you can actually see the fluid egressing, and you're afraid you've perforated, but it's not. It's just that egress. But still, I wouldn't push it by, going with a bigger needle.
Okay, there's two comments from our senior VR surgeon. So these first two comments are from Dr. Jaffaji, who says that gas results in faster clearance, 2 to 3 days, and the cornea clears. Advantages being it's conservative, it's a short procedure, and causes less scarring as per the pictures presented. Dr. Jaffaji says he's done several of them, and the discomfort is the patient has to have the head up. And then Dr. Situma says SF6 gas is not cheap, so probably that's a limiting, resource limiting. Dr. Mushai, there's a comment from Dr. Mushai. In VR setup, gas is easily accessible and we use tiny volumes. Has done several and the outcomes are great. I think that's it for the in-call comments and questions, Dr. Yeah.
Thank you.
Yeah, thank you, Dr. for the presentation. Maybe we hand back to Dr. Wanjiku, you can pick it up.
Okay, thank you very much. I believe I saw Dr. Mundia's hand up at some point. Dr. Mundia, did you want to say something?
No, thank you.
All right. Thank you so much, Dr. Muragori and Dr. Korir as well for that wonderful presentation. Very, very informative. Since we encounter hydrops quite a bit or once in a while, and then you try and remember what was I supposed to do. So thank you for that reminder and for the update on new methods of handling hydrops. Thank you everyone for participating and for showing up. Have a great week. We'll communicate the next CME. And OSK is coming up, so kindly consider, we'll continue registering. Thank you very much. Oh, Dr. Muragori, you want to say something?
No, sorry, mistake, sorry.
Hi, have a great week.